Hey, welcome to the Module 6 exam review video, part 3. This one will hopefully go by a lot quicker than the previous two, as even though we have a lot of topics, they don't really go as in depth. We'll try to make this quick. Let's get started. So the first thing we'll talk about is altered mental status. My biggest takeaway about altered mental status is that you all have to recognize anyone with AMS is in a potential life-threatening situation, right? So if your patient is not acting normally or is unable to act normally and they are confused or they're unresponsive or they only are responsive to verbal or painful stimuli, we just need to recognize that your patient is critical. There are many causes of altered mental status. I'm not going to list them all. Here it's bullet pointed a bunch of them, but honestly, think of anything and everything that could be severe enough, it's going to lead to altered mental status. When you do encounter a patient with altered mental status, then we kind of want to make sure that we take C-spine precautions, especially if they are found somewhere that a person is typically not going to lay down. So like if they're found on the side of the highway or on the floor of their kitchen, we have to consider that they ended up on the floor in a dangerous manner. We don't know how they got there, right? So make sure you take C-spine, and then you're going to manage their ABCs, because if you have a person who is altered and unable to respond, well, they're not likely to protect their own airway as well. So go through the ABCs, maintain their airway, suction if you have to, try to keep their SpO2 above 94%. If they have signs of respiratory failure, then go ahead and ventilate them and keep them supine while you transport them. Since your altered patient is a critical one, you want to reassess them every 5 minutes. And again, you're just looking for changes in their mental status, staying on top of their ABCs, and recording your vital signs when you can to establish those trends. In the meantime, you want to do a thorough secondary assessment. You want to go head to toe. We're looking for any and all reasons that is potentially causing your patient to be unresponsive or altered, since they are unable to reliably tell you themselves. So we want to work with speed and efficiency, managing the ABCs and transporting, but we do want to be thorough through all our sample history, looking for any other physical signs that could give us clues as to what could be wrong. Never assume that just one thing is wrong with your patient, right? We could have comorbidities or different things acting upon the patient together. And with that, we are now going to go ahead and dive into stroke. So, a stroke patient is when you have a deficiency in the nervous system function, and we call this a neurological deficit. So, if you recall when you did your spinal mobilization stations and you're checking, can you wiggle your fingers? Can you feel me touching you? We're all looking for those neurological deficits there. And if there is a deficit, then something is wrong with the central nervous system, meaning the brain or spinal cord. You are dealing with an acute stroke, we need to remember the mnemonic from the AHA of FAST, where F stands for facial droop, A stands for arm drift, S stands for slurred speech, and then T stands for time. And that time could either be the last time seen normal for the patient, or time to get to the hospital, or time is brain. But we do need to understand and remember the mnemonic of FAST for your exam. We should also understand that there are two main types of stroke. One is either caused by a blockage or clot, and we call that an ischemic stroke. The other one is caused by a rupture or a bleed, known as a hemorrhagic stroke. So in the field, we cannot distinguish between the two types. Therefore, we must get them to a hospital with a cath lab so that they can, take a picture and identify what type of stroke we're dealing with. If we are dealing with an ischemic stroke, remember this is a stroke where a cerebral artery is being occluded by a clot or a thrombus, then these patients are qualified to receive fibrinolytic drugs. And basically that just stands for clot busters, right? You can administer a drug that's going to go in there and break up the clot and restore blood flow. The key takeaway, that last bullet point, is that AFib or atrial fibrillation is typically a history finding that it will precipitate or lead to an ischemic stroke. When we're talking about hemorrhagic strokes, this can result into a rupture of a weakened artery. So think about your aneurysms, or even your dissections, but typically an aneurysm when it comes to the brain. High blood pressure can, typically lead to this. So these are our lead-in factors. Just recall that we are not going to give our patients aspirin if they're suffering from a stroke because, again, we can't differentiate between ischemic or hemorrhagic. If you give aspirin and it turns out to be a hemorrhagic stroke, then you are going to cause more harm than good. Oftentimes, your stroke patients will suffer paralysis affecting one side of the face or body versus the other. Here's just a slide to depict, what that facial droop could potentially look like. I really want you guys to be familiar with the difference between a stroke and a transient ischemic attack, otherwise known as TIAs. There are at least one or two questions on your exam that has you kind of identifying whether this is a TIA or not. And so the definition is that you have the same signs and symptoms of a stroke, whether it's facial droop, arm drift, slurred speech, or all of the above, and the symptoms will resolve in less than 5 minutes. Okay, just keep in mind that if your patient is experiencing TIAs and it goes away, it doesn't mean that your patient, is all better and they should just stay home. We have to understand that this is a risk factor that they are more likely to experience a full-blown stroke within the next couple days or so. Whenever you're assessing whether your patient has a stroke or TIA, we want to note where the patient is found, meaning like, is this a potential trauma patient or is this purely medical? So if your patient was found, on a kitchen chair or something with these neurological deficits, we can sort of safely assume that this is a stroke. If they are found like at the base of the stairs and they might have some bruising to their head and eyes, well then now you know that this is more likely like a head bleed due to trauma. Again, just assess your patients. We're always going to harp on those ABCs. So look for inadequate breathing, abnormal breathing patterns, and then manage it with the BVM as you see fit. For this last bullet point, we are going to recall, just like with your acute myocardial infarcts, your MIs, you don't want to administer too much oxygen to a stroke patient. So we want to stay above 94%, but anytime we get to 100 or we're saturated at 100%, then we increase that risk of reperfusion injury due to the free radicals that we're creating. For the purpose of this exam, we typically go over the Cincinnati Pre-Hospital Stroke Scale since this is what we typically use in Louisiana. I know the textbook states a few others or mentions a couple other stroke scales. You can review them as you see fit for the NREMT, but I'm pretty sure at National Registry they won't really cater to one scale versus the other. So since they know that different states and different systems go by different rules. But here's the Cincinnati Pre-Hospital Stroke Scale for you guys to just kind of look over and study for this exam. While managing your strokes or TIAs, you want to check a blood glucose level. Sometimes having a low blood sugar will mimic a stroke, and it's going to be very embarrassing if you bring your patient in calling in a stroke and it turns out that their blood sugar was just too low. We will also want to make sure that if the patient is unable to protect themselves or protect their extremities, that we're not just leaving it, dangling off the side of the stretcher as you push them through the door. And we also want to make sure that we establish rapid transport to the correct facility. So your highest level stroke center that is within reasonable driving distance should be your goal here. And we want to reassess our patient every 5 minutes because just because they showed up with a certain set of neurological deficits, we want to make sure that it's not getting worse or we're having more deficits or it's improving and now you're considering that this patient is having a TIA instead of a stroke. All right, the next topic, and this is the only slide I have on headaches. For the exam, I didn't really cover headaches too much. For National Registry or the final, you may want to review this topic again, but for the purpose of this video, I'm just going to talk about headaches here on the slide. You have various types: cluster headaches, tension headaches, migraines. Go back and read over what type of headache is what, but I'm letting you know now for this exam, we're not going to really touch on it. The next chapter we're diving into are seizures and syncopal episodes. So a seizure is defined as a sudden and temporary alteration in brain function caused by electrical discharges in the brain. I think seizures are something that any ENT should be able to recognize, and I'm sure you all have watched, a TV show or a Hollywood. This is probably one of the more, pronounced depictions out there. When we categorize our seizures, we might call them either primary or secondary seizures. And so the primary seizure is when, the cause is unknown or it's genetics or it's just something that involves, uh, the state of the patient already. These patients are typically, they've had some history of seizures somewhere and they know that they have seizures. They are very comfortable with how to manage themselves after a seizure. So, we're just there to support and initiate transport if they want to. The secondary seizure is a little bit more dangerous where it can be occurring from an underlying cause. And there are several causes, whether you have, you know, some kind of trauma or lack of oxygen or lack of glucose. And I think when it comes to our patients with primary seizures, because they're so used to the seizures occurring normally for them, they often, lose track of the fact that it could be caused by something else. So I think as EMS providers, whenever you encounter your patients experiencing a seizure, and if they're trying to blow you off, be thorough with your assessment, do the detective work, try to, rule out all causes just to make sure that the seizure wasn't caused by some underlying, issue. For this exam, you really need to know the definition of status epilepticus, and this is a life-threatening emergency. This is the most dangerous seizure you could have. By your textbook, it's defined as two or more sequential seizures without a full recovery of consciousness between them, or it's a continuous seizure that lasts longer than 30 minutes. Now, obviously, we're not going to sit there for, 27, 28 minutes and think, it's not status yet. So the rule is that if the seizure has lasted longer than 5 minutes, it more than likely will develop into status. So if the seizure has been going on for longer than 5 minutes, it's safe to say this is status epilepticus, and we need to initiate transport. For this slide, I want to highlight what a tonic-clonic seizure is in the terms of tonic versus clonic. So when we say a tonic seizure, that means your patient has excessive muscle tone. So think tonic to tone. If they are tensed up and stretching out, or they seem like they're contracted in and they're holding this weird posture, then you're dealing with a tonic seizure. When your patient has a clonic seizure, then we're thinking of a convulsive seizure. So that's your typical, shaking or spasms of the body and limbs to where, they have uncontrolled movements. And a tonic-clonic seizure is when you have, the presentation of both, where they start off in that tonic state and then proceed into a clonic seizure. Um, your patient is never awake or aware through any of this. So whenever you have patients trying to fake seizures and they describe what they were doing, how they got to the floor, or what happened to them, then it's not a true seizure, or at least not a true tonic-clonic seizure. All your tonic-clonic seizures will occur without any awareness, and most patients won't even recall any events of what happened. Generalized tonic-clonic seizure, there are a list of stages here. We want to define aura for your exam, and your aura is when you have like a warning sign. So different patients have different auras. They may have a certain taste or sight or sensation that kind of warns them that a seizure is about to take place. If this is something a patient deals with on the regular, they know what their aura is. They can often describe it to you or, take measures to protect themselves as they occur. The next phase is the loss of consciousness, and then you go into your tonic phase with that muscle rigidity or intense muscle tone, and then you go into your relaxed phase or your tensed up phase or your hypertonic phase, going into your clonic phase where you have convulsion, and then your postictal state. We want to be able to define what a postictal state is for your exam. And that's literally just the stage where your patient is recovering. So they're coming out of their seizure, but their mental status is still altered. They may be unresponsive or they're just confused and disoriented. Sometimes they're a little bit combative, but over time, their mental status is going to progressively improve. Here I have a bulleted list of other types of generalized seizures. I'm not going to go into too much details about each. I think you should review all of these for, the possible final or NREMT exam. The only ones I'll really highlight is maybe the absence seizure, which is known also as a petit mal seizure, and it's most common in kids. Um, these are characterized by like a sudden cessation or like they lose consciousness really quickly and then they just have this like they're not talking, they're just staring off into space and it doesn't last long. They end after maybe like 15, 20 seconds. The other one I'm going to highlight is the febrile seizure, where if your patient is experiencing a severely high fever that it starts to damage the brain, then you're going to see, a seizure as a result. And again, these are most common in your pediatric patients. So we'll just go ahead and highlight absence and febrile seizure there for you guys to carry forward. But again, if you're reviewing for the NREMT and final, I would try to be familiar with all of these. When we talk about partial seizures, then they involve abnormal movements of one area of the body. Your patient can be and typically is awake and aware, so they will kind of know what's going on. And it may just involve one body part or it'll spread to other areas. Honestly, I've never seen this in the field. And if it has happened, it's a very rare condition, or people just don't call 911 for it because they're aware of it. But just know that partial seizures do exist, and some people, it'll just be a very strange experience for them, but don't write them off. Similar to any patient experiencing altered mental status, we don't always know the cause for seizures, so you want to look for evidence of trauma or poisoning or even potential medical history. If the patient is postictal, they will be confused and, may not be able to respond appropriately, but you just got to give them time. If they are actively seizing, then you must move objects away from them, and that is pretty key in the management of seizures. Otherwise, do not restrain them. You kind of just have to let the seizures play out and protect their head as best you can. You may want to lay them on their side so that if they vomit, they can, they can expel out to the ground and not up into their own airway. Um, Insert an oral a nasal adjunct if you can and if you need to, and just make sure that their oxygen stays above 94%. So if you have a patient who is excessively convulsing and you're having trouble getting a mask or something on them, then just blow by oxygenation will work here. The last bit here is to also make sure that you check a blood glucose level, because if you have a low blood sugar, that could cause a seizure, or the seizure activity was so strenuous that it used up a lot of the blood glucose, and then you might have to replace it afterwards. I just threw this slide in here to, drive the point that we are protecting the seasoned patient from injury by moving furniture and objects away, and just so that y'all can be, familiar with that phrasing so that when you see it on the exam, you know what to answer. All right, so a syncope or a syncopal episode is any sudden temporary loss of consciousness. I think the layman terms for this would just be fainting. So if your patient had fainted, then they had a syncopal episode. A lot of times people like they interchange the definitions of syncope for a seizure, like they see someone drop and they say, oh, he had a seizure, when it's just a syncopal episode. I have this table here to help you guys differentiate between the two, but if you can witness a seizure, it'll probably be very obvious, that it's a seizure versus a syncopal episode. So make sure you do your history. If the patient isn't able to respond to you, then ask bystanders more so to describe what happened as opposed to, what they think happened. And here you might want to keep things with your open-ended questions, and if you're not getting the answers you need, then you use your closed-ended questions to pull specific details. So management of a syncopal episode, very similar to your altered mental status or seizure patients. You want to do your ABCs, do a thorough head to toe, keep them supine, make sure that you consider all causes. So, this really hand in hand with altered mental status. We don't know what caused them to faint, so we want to make sure that we look for any or all causes and encourage transport if we do happen to get them back. Um, One thing that often occurs is if your patient has a syncopal episode, they end up on the ground, and after laying on the ground for a few moments, they wake up again. But if they sit up or stand up too quickly, they have another syncopal episode. So it's not on the slide, but I just want you guys to kind of think about why that's the case, right? So if your patient is fainting from standing or sitting, but they are able to regain consciousness while laying down, then it's most likely due to the positioning of the patient that is helping them perfuse better, right? So just like our shock patients, we lay them supine so that we can perfuse to the brain and vital organs more easily. And it's the same concept here for your patients experiencing a syncopal episode. All right, the last chapter we'll talk about is diabetic emergencies. I know we've talked a little bit before about checking the blood sugar of various patients in all the previous chapters, but now we're diving into why that's so important. Recall from A&P or Module 2 that glucose is basically the energy that we use to, or the molecule we provide to break down for energy. So it is the primary energy source for your cells, and without it, your cells cannot function. With glucose, regulation of the blood glucose level is critical to normal cell function, and your brain cells use up the most glucose for energy. So, whenever you have a low blood glucose, one of the earliest signs is that altered mental status. And if you have a very long time of low blood glucose, then you're going to lead to the death of those cells. On the opposite spectrum, if there is too much glucose, then you can pull some water into the cell as it crosses that cell membrane, and that's going to make head injuries or strokes even worse. Also, with the high blood sugar, that glucose has to be excreted through the urine, and as it is excreted, it pulls excessive water with it, so that's going to lead to dehydration. Now, insulin is the main hormone that controls blood glucose levels, and we should recall that insulin is produced from the pancreas. So when insulin is secreted, it kind of signals to the cells that now is the time to pick up glucose from the bloodstream. So you have all this glucose just circulating in the bloodstream, and without insulin to tell the cells, to bring it inside, it's going to stay in the bloodstream. Here we have a couple images to help depict this. So on the left side, you can see that with insulin, the channel opens for glucose to enter, and then they metabolize it into energy. On the other side, on the right, if you don't have insulin, then glucose will stay in the bloodstream, and so your blood glucose level will start to get high. But your cell still needs energy somehow. So what they do is they metabolize fat to produce energy instead. And I know a lot of you guys are thinking, oh, that's awesome, but you also have to consider the byproducts of burning that fat is not always good for the body. And so this is kind of the premise to producing ketone bodies and part of the keto diet. But we'll talk more on that later. So the way insulin regulates your body or your blood glucose levels is we typically have a range, a normal range that is between 70 to 120. If you have a hard time remembering that, then we often say the trick is to think of what your normal blood pressure is, 120 over 80, 120 over 70, and that is your normal range for blood glucose. Anything higher than 120 is, too much blood sugar. Anything lower than 70 is too low. Um, but again, as you eat a meal and your increased blood glucose levels get higher, then insulin will secrete as a result. And this insulin will trigger your cells to uptake that blood glucose, and so your levels will drop. Um, if you're in between meals, like you haven't eaten for a very long time and you don't have any circulating blood sugar, then a hormone called glucagon is secreted instead, and this is kind of the trigger to break down your fat stores. This slide is reiterating some things from the last one, what your normal readings are, and we have the new terms hypoglycemia versus hyperglycemia, and hopefully we know these prefixes by now, that hypo means below and hyper means above or too high. Um, when you're assessing your patient, it is important to know the last time the patient ate or drank something, just to kind of give some reference onto whether the patient is uh, maintaining their blood glucose well enough or not. So when we talk about diabetes, diabetes is a disturbance in the metabolism of carbohydrates, fats, and proteins. And this can either result from a lack of production of insulin from the pancreas or an inability of the cells to respond to that insulin, sorry. If the patient doesn't manage their diabetes, then they will typically have a higher blood glucose level. And so we have the three P's of diabetes, which is polydipsia, which is an increased level of thirst, polyuria, which is an increased amount of urine production, and polyphagia, which is an increased hunger. So if you think about the what we talked about earlier, the glucose molecules pulling water with it, as you excrete it in your urine, the excessive glucose is going to pull water with it, causing you to urinate more frequently. But as you urinate more frequently, you become more dehydrated, so you achieve polydipsia, which is increased thirst. At the same time, you have an increased blood glucose level because the insulin isn't telling your cells to take it into the cell itself. And because the cells are constantly starved of glucose and they're having to break down fat stores to produce energy, they kind of signal to your brain that, hey, we need sugar or we need glucose and we're hungry. So you get the three P's of diabetes. We label diabetes into two types, and type 1 diabetes is where your pancreas does not secrete insulin on its own. Usually, this is some kind of genetic or autoimmune disorder where your immune cells have attacked the cells that produce insulin, and your patients have to rely on taking insulin in order to regulate blood glucose. So we often say your type 1 patients are insulin dependent. Um, these patients are more prone to diabetic ketoacidosis or DKA, which again we'll talk more about later. When we talk about type 2 diabetes, this is when your cells have become resistant or they're not responding to the insulin anymore. And therefore, they're not taking in, the blood glucose just because they've become immune to the response to it. And it's not so much that they require insulin. Some of them do take insulin still, but majority of these patients will have to regulate their blood sugar through diet and exercise, and just kind of like limiting the amount of blood sugar is available so that their body can regulate itself more easily. When we talk about our hypoglycemic emergencies, these are patients with the low blood sugar, and it's usually due to a patient that either takes insulin, but they either forgot to or they didn't eat enough, or you have a patient that's just kind of fasting and then, they take insulin anyways. Sometimes the patient will take too much insulin. So if you think about your geriatric patients that they may have forgotten they took a dose of insulin, so they take another. Um, you know, this is the usual causes of hypoglycemia. For the purpose of your exam, you do need to know the assessment findings of hypoglycemia. Like if you look at a patient, how can you tell if they are hypoglycemic versus hyperglycemic? First off, you're going to have that onset of altered mental status, right? So they might exhibit some bizarre behavior, and that's due to their low blood sugar. We always say, you're not you when you're hungry, so grab a Snickers. Other signs and symptoms occur from the release of epinephrine, and so you're going to see patients present with this, diaphoretic or sweating, and they're going to have this pale, cool, clammy skin, along with, weakness. If the patient has been hypoglycemic for several minutes, then we're going to see some brain cell dysfunction. And again, the altered mental status with confusion or drowsiness. They may be completely unresponsive, or you might even see them exhibit seizures or stroke-like symptoms, which is why we always rule out a blood glucose for those emergencies. When you are providing emergency care for these hypoglycemic patients, they are typically unresponsive or unable to follow commands, so they may not be able to protect their own airway. Therefore, we want to establish an open airway. If we have to provide positive pressure ventilations, go ahead and do so. Otherwise, again, we're just trying to keep oxygen above 94%. We want to check their blood glucose level, and then we may want to request ALS. If the patient is confused, but they're responsive and they're able to swallow or protect their own airway, follow commands, then we can administer a tube of oral glucose. So these are the patients that, they're not quite gone, but they're running a little bit slow, a little bit bizarre, but they're able to pretty much do what you ask. And, most of these patients are recognizing that their blood sugar is low, and they're going to be more than cooperative to eat or, take the oral glucose. I do want to backtrack a little bit about the unresponsive patients that you should not just pour or squeeze oral glucose into a patient that can't protect their airway. But your book will mention that there is, a method that we can employ where you take a small pearl drop of glucose onto your finger and you just smear it along their gums and on their cheeks. Is it going to work very quickly? No, but it's often better than doing nothing while you're waiting for ALS. And so for those patients that can't protect their airway, we want a paramedic or ALS on scene to start an IV and administer the dextrose through the vein. But again, if there's a long transport time or it's too long for IV access, you can start smearing some glucose on their gums and cheeks, check it every 5 minutes or so. And it'll take a long while, but again, it's better than letting your patient just stay hypoglycemic without doing anything. So, talking more about oral glucose, it is a gel, it's absorbed very quickly. Um, a lot of students like to ask, does it taste good? I don't really think so. Some of the newer brands reportedly taste better, but to each their own. Your patient, if they have altered mental status and they are low in blood sugar and they can swallow, then they can eat the whole tube, and you're going to give them the entire tube. Again, if there's any question on whether the patient can protect their own airway, we don't really want to squeeze like a whole tube in there. Instead, you want to just, smear it across the gums. For a patient that is alert and oriented, we'll just kind of squeeze a bit of it in between their cheek and gum so that, they can swallow it on their own. When we switch gears talking about hyperglycemia, this is high blood glucose levels caused by a relative lack of insulin or response to insulin. So the key one I'm going to highlight here is DKA, diabetic ketoacidosis. And what happens with DKA is your body is not receiving, or the cells of your body is not receiving glucose, and therefore it has to break down fat stores for energy. Well, in the process of breaking down those fat stores, it is creating what we call ketone bodies. And these ketone bodies are acidic in nature and damaging in large amounts. So we typically say that a patient is in DKA when their blood sugar is above 350. Um, Without insulin, again, they can't move glucose into the cells, so they starve, and now they are burning that fat, producing those ketone bodies. This doesn't happen very quickly. It often progresses over a few days. And in the process of this buildup of ketone bodies and excessive blood sugar, they're going to become more dehydrated. And you might see like poor skin turgor or they're going to develop what we call Kussmaul respirations, where they're breathing very hard and very fast. As they breathe really deep and rapidly with that Kussmaul respiration, they're what's happening is their body is trying to blow off carbon dioxide to reduce the acid load inside the body. And so if they continue to hyperventilate, then they'll reduce the amount of carbonic acid and thus reduce the total amount of acid in the body. Um, but again, signs and symptoms related to this, you're going to have dehydration, uh, excessive thirst, excessive urination. You're going to have signs of dehydration. Your patient may appear dry. They'll have dry skin instead of sweaty skin, and they're going to be flushed in appearance. So managing the patient in DKA, same principles, manage your ABCs, um, check their blood sugar level. If you're unsure of their condition, I would honestly call medical direction here and let them guide you on what to do next. For the purpose of this exam, I didn't really talk about hyperglycemic hyperosmolar non-ketotic syndrome, but it's basically a hyperglycemic patient without the production of ketone bodies. So management is basically the same, ABCs, check the blood sugar level, contact medical direction for guidance if you have to. If you want to know more details about HHNS, I would review it just in case NREMT asks you some questions regarding this. So in general, whenever you are dealing with a patient with altered mental status and a history of diabetes, we want to make sure that we are checking their blood sugar. We want to see if the administration of glucose is improving anything. If they're hypoglycemic, just keep in mind that administration with oral glucose is not a very fast procedure and it could take as long as 20 minutes. You want to be aggressive in checking their blood sugar just to see their trends, if it's going up or if it's going down. And if your patient is hyperglycemic, meaning that they're on the high side of things, and again, we're really just managing their ABCs and transporting them to the hospital. So this slide will conclude my review video, part 3. I hope it wasn't too long and we highlighted all the key points. I try to, give y'all some tidbits throughout all 3 videos on what will assuredly be on the exam and what isn't going to be on the exam to try to save you some study time. Again, though, a lot of the materials that I did skip or say not to worry about this exam, we want to make sure that we try to at least review those items in case the National Registry exam brings them up. So with that, I wish you luck.